Hi, this is Andrea Kane, and I'm here with you for HIT 292, where we're looking at reimbursement methodologies. This is week 1, lecture over chapter 1. So we're using our book Principles of Healthcare Reimbursement and Revenue Cycle Management, and we're looking at the basics of those topics. So let's get started. Our learning objectives, at least according to our book, are to distinguish between the social insurance, National Health Service, and private health insurance healthcare delivery models, describe the U.S. healthcare business model, define health insurance, explain the connection between U.S. health insurance and employment, define revenue integrity, and identify the 3 main components of the revenue cycle. So let's get started. Why should we learn about healthcare reimbursement? Well, we're needed to assist patients, to garner accurate revenue for healthcare organizations, and to assist the public with navigating the business side of healthcare. We can learn to do this by learning about healthcare reimbursement step by step, learning the terms, jargon, and abbreviations, the payer's policies and procedures, and each payer has their own policies and procedures, as well as each healthcare facility or healthcare organization has policies and procedures as well as processes. So let's look at some beginning key terms. Reimbursement means compensation or repayment for healthcare services already delivered. Revenue cycle means a regular set of tasks and activities that produce reimbursement or revenue. Revenue cycle management is the supervision of all administrative and clinical functions that contribute to the capture, management, and collection of patient service reimbursement. There are 3 basic national models of healthcare delivery around the world. We are going to talk about these. These should be familiar to you probably a bit through HIT 330 if you think back quite a bit ago. The social insurance model is also known as a Bismarck model. This is where you have universal health care coverage for a set of benefits defined by the national government. The amount of contributions are proportionate to the workers' and employers' incomes. A good example of this would be Germany, or Germany would be a really good example of this. National health insurance model is also known as the Beveridge model. This is where the government owns the clinics and hospitals and pays the doctors and health personnel who work in these public facilities. There's a single payer system financed by the country's general revenues, taxes. This is the kind of thing that you find in Great Britain, in the Netherlands, and several other countries around the world. Then you have, I believe China is another one. You find national health insurance model. Canada would be another one. So those types of things. Private health insurance model is the United States. This is where many private health insurance companies exist in addition to federally run programs. Private insurance companies determine the premium, but it's not based on income. It's based rather than on past health and risk assessment of future health. Healthcare delivery in the United States. The U.S. healthcare sector accounted for $3.6 trillion, that's trillion with a T, or 70.7% of the nation's gross domestic product in 2018, and that has only increased. There has been a consistent trend for more than a decade where expenditures continue to increase, but the rate of the increase was on a downward trend. Notice, however, this was before COVID. So under COVID, expenses increased, but the rate of increase also increased for the first time in quite some time. So just be aware of that twist that's not reflected in this slide. The U.S. healthcare business model is one where you have patients, providers, third-party payers, and employers. And it's a dance between those different parties and parts and who does what. And this is all in your textbook, so please refer back to there for details. They give us this comparison of the healthcare business model to the grocery store business model. And again, I'm going to refer you back to your book for this. It has some similarities. I'm not convinced this is the best way to compare them, but your textbook thinks it is. So I'll leave it up to you to decide what you think. Health insurance is reducing a person's exposure to risk of loss by having another party assume the risk. The distribution of risk across, and this word should be pool, not poll. It should be P-O-O-L, not P-O-L-L, to account for varying health statuses, estimate of average cost. Risk is the probability of incurring loss. A risk pool is a group of people who will be covered by a health insurance plan. So you want a pretty broad risk pool so that you have a good chance of managing your risk. Policyholder, that's an individual or entity that purchases health insurance coverage. A beneficiary is an individual who's eligible for benefits from that health plan. So you may have someone who's policyholder and beneficiary. You may have someone who's just a beneficiary but not a policyholder. Health insurance premiums. It's a dollar amount that the policyholder or certificate holder must periodically pay a health insurance plan in return for healthcare coverage. The insurance company assumes the insured's exposure to risk of loss in return for the premium. Actuarial data is used to calculate the amount of premium needed to cover all the group's potential health costs. That's why you want to have that broad risk pool. Insurance company pools premiums to ensure that the pool is large enough to pay losses for the entire group. That's why they like to have those young, healthy individuals as much as possible to offset maybe those that are older or those who have chronic diseases that they know are going to use quite a bit of healthcare cost. Looking back at a historical perspective, your book goes through this in detail, so I'm just going to kind of skim through here. But in the early 1900s, individuals purchased sick funds instead of health insurance. The sickness funds acted like today's disability insurance. You only used it if you became disabled. Many European countries had adopted forms of nationalized health insurance by the 1920s. In the U.S., efforts for the compulsory nationalized health insurance were opposed by physicians, pharmaceutical firms, and insurance companies. And even though the U.S. Has tried many times since the 1920s to implement a nationalized health insurance or a nationalized health system, those types of things, the opposition has been so strong that they've not been successful. The U.S. has developed their healthcare delivery system and evolved starting in 1929 when first insurance was offered by Blue Cross Blue Shield to school teachers in Texas. Then you had the 1940s and World War II. You had executive and judicial acts that addressed labor shortages, and insurance became linked to employment, and you had a basic structure of U.S. insurance and healthcare delivery occur. So even though you had insurance first being offered in 1929, it wasn't until the 1940s, World War II, and that era that it really became entrenched and it became part of employment. So for larger employers, health insurance is part of an employment benefit package. But what happens when people lose their jobs? They often lose their health insurance. There are two options to that. COBRA, and anyone who's ever received paperwork for COBRA knows, yes, you can extend your health insurance, but it is unbelievably expensive. It's about like 3 times what it was when you were in an employment benefit package. So COBRA, for the most part, prices people out. It's too expensive for them to continue to extend that health insurance. That's where the Affordable Care Act came in. They were hoping to enroll people in the federal marketplace where they would have large enough risk pools to have health insurance coverage that would be similar in cost to an employment benefit package. In some ways that occurred, in some ways it didn't. But that was part of what was behind the Affordable Care Act. When you're talking about third-party payment, the first party is a patient, the second party is a provider, the third party is the payer, and obviously that third party has the right to get in between the provider and the patient when you're talking about payment and delivery of healthcare services, what they're willing to cover. Revenue cycle management is most successful when it is a multidisciplinary model, promoting collaboration, emphasizing education, and taking a proactive stance for reimbursement issues. Revenue integrity. The principles behind revenue integrity include performing revenue cycle duties to obtain operational efficiency and compliance adherence as well as legitimate reimbursement. Goals are to produce a claim that is clean, complete, and compliant. Clean meaning free of errors, complete meaning all services and supplies are reflected, and compliant meaning it adheres to contract requirements, regulations, and laws. This slide is crucial. I will tell you, you need to know what is on it for your quiz. Hint, hint, hint. Integrated revenue cycle is when it occurs when hospitals or health systems purchase other facilities or provider practices and they merge the revenue cycles. There are some benefits to this. You reduce your cost to collect. You can create consistent performance and measure that, manage that, ensure that that happens. And then you have coordinated strategic goals. But the challenges you face is oftentimes there are different payment systems and you have provider resistance, sometimes employee resistance too. But integrated revenue cycle is by far the norm and certainly what is expected in the world these days. So make sure that you understand that. Components of the revenue cycle, you have front-end processes, also known as patient engagement. That's like scheduling, registration, those types of things. Then you have middle processes, which is resource tracking. Oh, and in front-end process, that's also pre-authorization. Middle process is resource tracking. That's where you actually provide the service. It gets coded. The documentation is there. Then you have your back-end processes where you've already produced your claim, or you're producing your claim, you're submitting your claim, and you're doing revenue collection. So the three components of the revenue cycle: front end, middle, back end. Front end is everything prior to the patient receiving service. Middle is the patient receiving service up to the point before the claim is actually produced and released. And the back end is from claim production and release all the way through to revenue collection and all bookkeeping, accounting, those types of things. When you look at revenue cycle from the patient's perspective, it's fairly simple. They're scheduled for treatment, they are admitted, they pay their cost sharing portion, treatment is provided, supplies are used, resources are consumed, they're discharged, they receive an EOB, explanation of benefits, then they receive a bill from the facility and or physician. That's what they see. The provider facility perspective is much more complex. You start with patient being scheduled and pre-authorized, then they're admitted, you collect their demographic and payer information as well as their cost sharing portion. Services are delivered to the patient and you hope documented appropriately. Charges are captured, medical records are reviewed and coded, the claim is produced, audited, scrubbed, and corrected. It's then transmitted to the payer. Accounts are managed until all payments are received. Payments and remittance advice, or RA, are received from the payer, and then outstanding cost-sharing payments are collected from the patient. This is just information about how the textbook creates patient connection, and they take these fake or example patients and they take us through our book and expose them to different things. So it's just reminding you here that they're introducing the patients, that they're going to follow through the book and follow through these different scenarios. The first one is called Malachi. He's a 68-year-old male enrolled in Medicare. The second one is Olivia, a 30-year-old female who has commercial insurance through SuperPayer for her family through her employer. So we'll be seeing them as we move through. So this is where they're introducing the third-party payer concept. They're giving us a physician, and they're saying, oh, we've got an office visit. So this is what they're trying to say, is that the first party is the individual, the second party is their physician or their provider, the third party is either Medicare or SuperPayer, and how that involves with a third-party payment in between. And that is it for Chapter 1. I'll be back next week to talk to you more about reimbursement methodologies. Hope you have a fabulous week. Thank you and take care.